This tutorial is about cranial neuralgias and facial pain. First, we have 13.1, pain attributed to a lesion or disease of the trigeminal nerve. This is subdivided into trigeminal neuralgia with its typical electric shooting pains and painful trigeminal neuropathy, where something is bothering the nerve, but it does not result in these shooting pains, but more in a boring, constant nagging pain. The trigeminal neuralgia is subdivided into classical trigeminal neuralgia, secondary trigeminal neuralgia, and idiopathic trigeminal neuralgia, and we get back to this in a moment. And the painful trigeminal neuropathy can be caused by a number of things, and we mention here specifically herpes infection and post-herpetic neuralgia, post-traumatic neuralgia, and then neuralgia attributed to other disorders such as a tumor, for example, or inflammation. And there's also idiopathic, where we don't know why the patient has these chronic trigeminal pains. We have an explicit diagnostic criteria for trigeminal neuralgia in general, and then we have criteria for the subtypes of trigeminal neuralgia. And here are the criteria for trigeminal neuralgia unspecified, and these are recurrent paroxysms of unilateral facial pain in the distribution of one or more divisions of the trigeminal nerve, with no radiation beyond the territory or supply of the trigeminal nerve. Then it has to fulfill also pain characteristics. The pains are short-lasting, lasting only a fraction of a second up to 2 minutes, severe intensity, and they have electric shock-like shooting, stabbing, sharp quality. And it's precipitated by innocuous stimulation of the affected trigeminal distribution. And you notice immediately here that we have maybe some problems with the definition here, because what do we do if a patient has an otherwise typical trigeminal neuralgia, but it's not precipitated by innocuous stimuli? That's the danger of what we call monothetic diagnostic criteria. There are always patients who are different, and they cannot be included in the current definition. Now we get to the subtypes of trigeminal neuralgia. And the first and most important is classical trigeminal neuralgia. And these pains have the same characteristics that we just discussed under the general criteria for trigeminal neuralgia. And then there is MR verified contact between an artery and the trigeminal nerve, and there are morphological changes in the nerve in terms of displacement or atrophy. These findings are only present in about half of all patients with trigeminal neuralgia. Painful trigeminal neuropathy attributed to herpes zoster, and we have criterion showing that that there is a herpes infection, has been a herpes infection, but also we have another kind of pain. The pain is more nagging, boring, constant in quality, and it has to be present for at least some time. Glossopharyngeal neuralgia a rare, very rare disorder, but it is has the same quality as the trigeminal neuralgia with these sharp shooting pains, but located in the territory of supply of the glossopharyngeal nerve. And again, any underlying organic disorder has been ruled out. Then we have occipital neuralgia. And again, we have these same characteristics with the severe intensity, shooting, stabbing, sharp quality, recurring in paroxysms lasting from seconds to minutes. But in occipital neuralgia, there are some additional diagnostic criteria, because pain has to be associated with dysesthesia or allodynia in the affected area, or and it also has one of two, either tenderness of the affected trigeminal nerve branches or trigger points in the emergence of the greater occipital nerve. And finally, it has to be eased temporarily by local anesthetic block of the affected nerve. So there are actually a lot of criteria that needs to be fulfilled here in order to have occipital neuralgia. And there is no scientific study available at the moment where people have looked for patients fulfilling these diagnostic criteria. So this is an example of many possible examples of research that is needed to improve the future classification. Classification research is a whole branch of headache research, which unfortunately is not as popular as it should be, but still activity in this field has been picking up. The Tolosa-Hunt syndrome is also called painful ophthalmoplegia, and these patients have pain in, behind, or around one eye. They also have to have, according to the criteria, MR demonstration of a granulomatous inflammation of the cavernous sinus, superior orbital fissure or orbit. And what we do with patients who are otherwise typical, but where such changes cannot be shown by MR, is quite uncertain. There is a paresis of one or more of the third, fourth, and sixth cranial nerve. And headache is ipsilateral to the demonstrated inflammation, or headache has, and headache is present. It can be present up to 2 weeks before the ophthalmoplegia, but also occur with the ophthalmoplegia. Then we have burning mouth syndrome, and it's a little bit unclear why it's actually included in the headache classification, because these are patients who have burning pain in the mouth, but not headache. It's felt superficially in the mucosa, and there are no signs of any disease of the mucosa. So it's a kind of or primary or idiopathic kind of pain, but it's something that's very often seen by dentists, and its etiology is completely unknown. Lastly, here in this group we have persistent idiopathic facial pain, PIFP, which was previously called atypical facial pain, and this is, of course, a very common problem. People have pain in the face, which is usually constantly present, but here its requirement is at least 2 hours per day. every day for 3 months in order to have the diagnosis. It's poorly localized and doesn't follow the distribution of a branch of the trigeminal nerve. And in contrast to trigeminal neuralgia, the pain is dull, aching, or nagging in quality. The clinical neurological examination is normal, and the dental examination does not reveal any cause of this syndrome. So again, it's a kind of primary or idiopathic pain syndrome, as we all know, very difficult to treat, not responding to the treatments that are so effective in trigeminal neuralgia, like carbamazepine, oxcarbazepine, and so on. It's usually mostly treated by tricyclic antidepressants with some success. This was about facial or pain and the cranial neuralgias, but we also have a chapter 14, and chapter 14 is supposed to pick up all the patients who don't fit into the classification, the preceding 13 chapters of the classification. It's divided into 2 different kinds: headache not elsewhere classified. What that means is this is a new kind of headache. And we have seen in recent years there are still new kinds of headache being described that have never been described before. A good example is headache caused by airplane travel, which was only described and accepted in the latest edition of the International Headache Classification. But I'm sure there are many other hitherto undescribed typical entities of headache, and so there is more Sherlock Holmes work to be done by headache specialists. The other is called headache unspecified, and that is meant for patients where you just don't have the necessary information. Let's say you do a chart review and you want to classify the patients with headache, but in the chart you just don't have the necessary information. Then you can use this diagnosis, headache unspecified. So that was a short discussion of cranial neuralgias, facial pain, and also of the chapter 14 cases. Thank you very much.